like to speak for about 30 minutes on why we need performance measures. And then I'm going to show you some of the data that we've published that I think really justifies the power and strength of using performance indicators to change clinical practice. This is the same disclosure that I've had before. Why is there so much attention? I mentioned this yesterday. There's so much attention in the United States. It's the single most expensive disease that's treated. So it's $60 billion a year that's spent on sepsis. And just as important, we heard yesterday, the long-term effects of sepsis. People don't go back to work for 6 months. They have cognitive disorders. And so we know that when you survive sepsis in the ICU, you have serious long-term consequences. And that's why there's so much attention, not just the money, but the impact and burden globally for sepsis. So I want to talk a little bit about the difference between bundles, checklists, and measures. And I want to go through this because I hear a lot of people say, I don't like bundles. I like checklists. And sometimes I think that it's a matter of terminology, not accuracy. So I just want to take you through what I mean when I say these things. So clinical practice guidelines are clearly defined methodology to make evidence-based recommendations. And I will show you some of the Surviving Sepsis Campaign guidelines in a moment. Bundles, which are derived from the guidelines, are used to implement guidelines at the bedside. So I said yesterday, we know that to a great extent, we have these big guidelines and we put them down on our desk and we never look at them again. And so the idea of bundles is to change clinical practice based on guidelines. Measures are a way to track performance with bundles. And there are a number of measures. I don't know if in Colombia, in the United States, we're held accountable for urinary tract infections, catheter-related CAUTIs, and
infecciones urinarias y también infecciones asociadas con la
in Colombia. Yeah, so we get penalized by our government if we have too high a rate of CLABSIs and too many central catheter-related urinary tract infections. So we pay a lot of attention. Those are measures. That's how the government and other places track our performance. So measures are also important. And finally, protocols. We all know what protocols are. They're simply ways for implementing guidelines. So protocols, we have, for instance, an alcohol withdrawal protocol in our medical intensive care unit that we use very successfully, and it's symptom triggered. So protocols are a way to operationalize guidelines. I'm happy to talk more about that. So why do we need performance measures? So I'm going to show you a series. Of studies that I think are very interesting and a little bit frightening. The basic question is, do clinicians perform better when we simply rely on our clinical judgment? Now, I know all of you and most physicians have their patients' best interests at heart. Of course, we take the Hippocratic Oath, we feel dedicated to patient care. But as I've said in a couple of talks yesterday, we get so busy that sometimes we forget to do the right thing and the easy thing for our patients. So the question is there wide variability in care, and is it good or bad? So I want to show you the problem is, I think, that we need to standardize care. And I showed you some of the bundles yesterday. I showed you the bundles in the talk on the 1 hour bundle. And the point of bundles is to create a minimum standard of care for sepsis in this case. now I'm going to show you this study, and this is the difference between what we think we do and what actually happens at the bedside. And this came out of Conrad Weinhardt, who's just a dear friend and a brilliant intensivist from Germany. Conrad was one of the first to introduce biomarkers. He did a lot of the early work with procalcitonin. So Conrad went to 40 ICUs in Germany, and you got to give him credit for being willing to publish this. He gave them what is a Likert scale, and so 92% of the intensivists in these 40 ICUs, he asked them about lung protective ventilation. And 92% said they always, or they sometimes or always practice best lung protective strategies. So 92% ranked it as 4 or 5. So what do you think the next line's going to be? So then, just let me say, then they spent 2 weeks in the 40 ICUs. This was funded by the government. And they actually observed how many patients were getting 6 cc's per kilogram as a tidal volume. So what do you think the next number is going to be after the audit? Right. 4%. 4%. Now I have to say, I'm not sure I would publish this, but Conrad has a lot of ethics, and that's what he found. And I think this is a great message that says there's a huge difference between what we think we're doing at the bedside and what actually is happening. And honestly, until someone comes to your bedside and monitors it, you really don't know. And so this is very eye-opening, as we say. This is another study that's also very frightening. This was a systematic review. This was published in the Annals of the Journal of the American. It was published in JAMA in 2006. And basically, they reviewed 17 articles, and they looked to see the difference of practicing standard of care and how long physicians had been out of practice. So, here it is. So what you see here, this is studies in which the length of time in practice was associated with higher performance for all outcomes. Studies in which the length of time in practice or age was associated with lower performance. So I don't know if you can see in the back, look at the small amount of white bars. All the bars are either black or gray. So this is very interesting. This says that, you know how you hear some physicians say, I've been doing it this way for years. Well, what if it's bad? This is what this article says. This was 17 reviews comparing performance measures and the age and length, the age of time out of training and the age of the physician, the intensivist. This really raises the question that just because I've been practicing for 25 years doesn't mean I'm doing it correctly. This, I think, is why we need to standardize care through the use of measures and bundles. So let's look on, and I threw this cartoon in. It's true. Knowledge is like paint. It really is no good until it's applied. So if you leave the paint in the can, if you leave the best practiced standards in the can, instead of applying it to our patients, if we leave the guidelines in the can and don't paint the walls with it, it doesn't help very much. This may seem harsh, but we know as physicians, sometimes we're attached to doing things my way. And that's a very dangerous trap. So this is what gave rise to the Surviving Sepsis campaign. This is the timeline. We have been doing the Surviving Sepsis campaign for over 20 years now. And we had, first, it started in 2002 at the European Society of Intensive Care meeting. It was a declaration to dedicate ourselves to improving survival in sepsis. And we said that our goal was 25% reduction, a relative risk reduction in the mortality from sepsis over 5 years. We managed to do it in 7 years, but still, and I have to confess, this was a bit in a bar on the back of a napkin. We sort of invented how much we could reduce sepsis. And we calculated that that would lead to 72,000 lives saved in the United States and 500,000 lives saved worldwide if we were able to reduce it by 25%. So then we produced the evidence-based guidelines. And I think you all know the evidence-based guidelines. We're about to work on the 6th iteration that'll be published in 2024 or 25. We're hoping that the Colombian Society of Intensive Care Medicine will become part of the supporters of the Surviving Sepsis Campaign guidelines. The most important thing to say is this has become the global standard of care. And there are 35 societies that have signed on to the Surviving Sepsis Campaign guidelines. And the remarkable thing is that one of the things that characterizes our field is a lot of competition by different national societies to have guidelines. And when we had end-of-life care guidelines, I was on 3 separate guidelines committees in the Society of Critical Care Medicine, the American Thoracic Society, and the American College of Chest Physicians, all within the United States. So the fact that there's a single set of consensus guidelines is a very important statement about the need for the sepsis guidelines globally. And obviously, we're at 2021. We just empowered the panel for 2025, 24, 25. Massimo Antonelli, who's speaking at this conference from Rome, and Haley Prescott from the University of Michigan are co-chairing the guidelines this time. So let me show you a little bit about the data that we have published in support of the guidelines. What we did for phase 3 was partner, and I mentioned this yesterday, we partnered with the Institute for Healthcare Improvement. And I won't take up much more time. I'll say again, this is the same slide I showed yesterday. The key to bundles is that they're linked in time and they're easy to measure. Those are the 2 key elements of bundles, that they basically have to be date, yes or no. So did you measure a lactate? If so, what date? And did you, yes or no? So that's that it has to be relatively easy to do a chart review and just check yes or no and write date down. And then finally, it's got to be linked in time. If you say, okay, on Tuesdays, Thursdays, and Saturdays, we're going to measure sepsis performance, it can't be like that. It has to be a short period of time. So either 6 hours and 24 hours or 3 and 6 hours, and I'll show you that in a moment. So these were the original bundles that we first tested, and I'm going to show you the data in a moment. It was 6 hours and 24 hours. So this was the resuscitation bundle, which was lactate, blood cultures, broad spectrum antibiotics, and in the event of hypotension or lactate greater than 4, give, in those days, it was 20 as opposed to 30 cc, and then put a central line in if needed. This was the management bundle, and obviously drug-to-cogen alpha is now off the market. We recommended steroids in those days, as well as tight glucose control. So you can see already times have changed. This was done in 2004. We agreed on these elements. This then, I'll talk about that in a second. So the way we did this was a global campaign that occurred in Europe, North America, and Latin America, mainly Brazil and Argentina. So there were 220 hospitals on 3 continents. And the primary outcome, and I want to emphasize this, the primary outcome variable was, can we change practice by compliance with the bundles? And we felt confident that because the bundles are evidence-based, that mortality would follow suit. So the higher compliance would lead to a lower mortality. And I'll show you those data in a moment. We built, there were, as I mentioned, 220 hospitals in 3 continents. We had 30,000 patients in the database. When we published it, it took us 7.5 years instead of 5 years. And then we had a website that hospitals could talk to each other through the website. And we gave them quarterly reports about their performance with indicators. So this was published in Critical Care Medicine and Intensive Care Medicine in 2015. And you see here something that's, this is very important. So the longer you participated, this is it, 3 to 4 years, the lower your mortality. You see your mortality comes here. So the lower your mortality. So for every quarter participation, the mortality in the hospital that was doing it dropped by 1%. The sepsis in hospital sepsis mortality. Those are really powerful data. And I'll show you this again in a moment, just like we demonstrated in New York State that I showed you yesterday, the higher compliance was associated with a steeper drop in mortality. So the longer you participated, any participation at all improved survival. The longer you participated, the better your survival, and the higher your compliance with indicators, the better your survival. So to me, again, this is a prospective cohort. So you could never prove cause and effect, but the fact that the longer you participated, any participation, and the better your compliance, to me was really good support for the association between performance measures and survival. So this then morphed and was changed in 2015 based on an analysis of the database at the time. And so we changed that to the 3 and 6 hour bundles, which exist to this day as the recommended bundle. I introduced yesterday, I remember, the 1 hour bundle, but there's still enough controversy. So right now, for the moment, it's the 3 and 6 hour bundle. We have a randomized control trial in which we're trying to prove in 18 sites, the 9 sites were randomized to 1 hour and 9 sites were randomized to 3 hours. It's all emergency department patients. And it's a 4-year study at the end of which we'll have an answer whether the hour 1 bundle or the 3 hour bundle are better for patient care, higher survival. So this is the 3 and 6 hour bundle. We then tested this bundle in the New York State mandated initiative. I talked about this a little bit earlier. There were 300 hospitals that were mandated to report their compliance with the 3 and 6 hour bundles by the Department of Health in the state of New York. And it's one of the largest states in the United States. And you can see here the same thing is true. This is the 3 hour bundle, and this is the 6 hour bundle. This is a 2-year period. And basically, over the course of the 2 years, there was a statistically significant decrease in mortality between the groups. And so, again, really good evidence that the longer you participate, any participation at all, and the longer you participate, the better your survival. More importantly, we then looked, just as we looked at already, we looked at quartiles of compliance. And I showed you this slide yesterday. So we divided the compliance levels into 4 quartiles. And you can see here that the lowest quartile, the mortality rate was 28, about 30, then 26, then 25, and then 23. And this was all statistically significant. So really good evidence that the higher your compliance, the lower your mortality rate. I think this is strong support for the value of performance measures. We then published this in the New England Journal. Seymour was the lead author, was also from New York State. We were able to demonstrate a linear increase in the likelihood of dying for every hour delay of achieving the three bundle. This was in all emergency department patients. So this was 75,000 patients. And you see here, the same thing is true for antibiotics. So basically, and we already talked about this yesterday, the longer we take to comply with the sepsis bundles, the higher the risk of dying is in the emergency department. And the longer it takes for us to get antibiotics on board, the higher the risk of dying. Again, as I said yesterday, this should not come as a shock to us. It should be obvious, and yet there's still a lot of controversy about giving antibiotics. This I showed you yesterday also. This was published in JAMA. Here we were able to demonstrate, and this was all in children under the age of 18. We were able to demonstrate, and this gave rise in many ways to the hour one bundle. We were able to demonstrate that for children under the age of 18, if they completed the bundle within 1 hour, they had a statistically significant survival benefit. So this in many ways was the evidence that we used to inform the hour one bundle. And there have been several, there's at least 2 meta-analyses in the literature. Remember, these are meta-analyses of prospective data, right? And so it's always a little dangerous to do a meta-analysis of prospective cohorts. Nonetheless, all of them, there are 40 studies here that have been published in the literature, and the one that was done by the NIH, the clinical group at the NIH, included about 18 studies, all prospective cohorts that all demonstrated improved survival associated with compliance with the use of performance measures. So this is SEP1. This is a manuscript that we published. It was SEP1, as I mentioned already, is the nationally mandated compliance for sepsis measures. And we were able to demonstrate the survival in 300,000 patients. And you can see here that we built a propensity score. This is the pass rate. This was statistically significant. And this was the difference between compliance versus non-compliance. You see compliance was 21% mortality. Non-compliance was 38% compliance. And we were able to match these patients with a propensity score. This was published in Chest last year, also demonstrating the power of using performance measures to drive clinical practice. And I'll skip over this. This is the study that I alluded to. It's funded by the National Institutes of Health, which is our national funding agency in the US. It's a 5-year study that started in July of this year. I'm the principal investigator. It's a cluster randomized controlled trial of testing the 1 hour versus the 3 hour bundle in the emergency department in 18 sites. So it'll be interesting to see what the results are. It's the first randomized controlled trial demonstrating the first RCT demonstrating the value of one of the 2 bundles. This is, I mentioned this already yesterday morning. This is the hour one bundle. I showed you some of the cartoons and the blogs that compared me to Darth Vader as a result of publishing this bundle, and that's fine. So I just want to end with a few words. Someone asked me this yesterday in the question and answer. Clearly, one size doesn't fit all, right? I mean, having guidelines, a set of guidelines, acts as if there's one patient in the world for whom these guidelines apply. But until we can really achieve true precision-based medicine, this is the best we have. So remember, the bundles are meant as a guideline, a minimum data set. I think that, of course, we need individualized therapy for sepsis, but the truth is, and I talked about this yesterday, right now, it's easy for me to stand up here and say, we need individualized treatment for sepsis when it's not possible right now. It's just simply not possible. And we're getting closer. We're able to identify, I showed you yesterday, different phenotypes for identifying subgroups that might or might not benefit, or it might cause harm. And so we're getting closer. But the truth is, right now, in 2023, 2024, it is not possible to individualize therapy for a given septic patient. And that's why I think that the bundles are still the best thing we have. I think until we can truly personalize sepsis therapy, we know there's wide variation in care. I showed you some of that already. This variation is not necessarily due to physiologic variation or individual patient responses. It's inconsistent application of known best practice models. And I said this, I showed you this yesterday. We're all so busy. It's hard to keep track. Do I pull the catheter out? Do I pull the urinary catheter out? Am I going to get dinged for this? Am I going to get punished? Is my hospital going to get punished? So there's so many things to keep track of. It's easy for us to forget to remember, or the house staff forget to remember to order the antibiotics or give the right amount of fluids to a patient. So bundles are meant and intended as a minimal treatment. Of course you can do more. And the truth is that, and I just hopefully showed that to you, the published evidence on sepsis bundles demonstrates a clear association with a survival benefit. I think the data strongly suggest early treatment is associated with improved survival. I think the data demonstrates increased mortality associated with every hour delay in management. I showed you that for the bundles. I showed you that for antibiotics. Yesterday, I showed you that for fluids as well. So clearly the data are the earlier we treat these patients, the better. And I think that this is really important. Sometimes when you read about the controversies in the medical literature, you would think that there's a huge volume of published data about the unintended or deleterious consequences of following bundles. But I'm saying that there are no published studies that demonstrate deleterious effects of sepsis bundles. I'm going to say that again. There are no published studies that demonstrate deleterious effects of sepsis bundles. And yet, we read these emotional pieces that are in the literature all the time. Oh, this is terrible. The Surviving Sepsis campaign is ruining the field of sepsis. It's preventing us from thinking, when there's no published data that demonstrate deleterious effects of sepsis bundles. I think bundles and measures are meant as guidance. And I said this yesterday, if you think that giving fluids, or for that matter, giving antibiotics, is bad for your patients, don't do it. It's just simply meant as guidance. If you think it's going to harm your patient, don't do it. And with that, I'll say thank you.